Thank you, Jen. Artificial intelligence, or AI, is beginning to reinvent healthcare in all its forms. AI is transforming every part of the system that it touches. Many hospitals and health systems have started to use it. Others have yet to start. And yet, for all, AI raises new and significant risks that we need to understand and manage. So it is my privilege to join our distinguished panel of experts today to explore how their organizations are using this technology to transform as its functionality evolves. In this discussion, we'll focus less on the familiar forms of AI, such as predictive modeling and robotic process automation that are already in wide use. Instead, we'll focus on newer forms, such as generative AI. In that context, we want to discuss how responsible AI is evolving as a healthcare discipline to drive value for patients, providers, and operators, and also to address issues such as data literacy, security, bias, compliance, and trust. As Jen said, if at any time during the discussion you have a question, please submit it. We'll take time at the end to respond to those questions we receive. With that, let's get started with how provider organizations are thinking about AI. In particular, how that thinking is influenced by the current state of healthcare and its digital transformation. Brian, should we be thinking differently about AI capabilities for organizations than we have for, say, other technology solutions?
I think the answer to that is yes and no. And I'll try to explain that briefly. So the no part is maybe idiosyncratic to me, but throughout my career, I've always looked at both opportunities and challenges with three simple questions. How's this impact our patients? How's this impact our team members? And how's this impact our numbers? And I think that this AI piece here really sits nicely into those three constructs to look at it. So that's the no part. The yes part is clearly this is something that is different, and it's something that's transformative, and it's something that's going to happen whether we like it or not. And Joe, I know you have a large cohort of trainees and students, and we have some number of those. And I know that they're already using generative AI to help them do what they need to do. And I think our challenge in healthcare right now is how do we begin to put this in a package in a way that really focuses on how we're going to enhance patient care with this and support that. How are we going to gain operational efficiencies? Because I think that there is a tremendous opportunity there. But the difference is going to be how does this work alongside our team members as opposed to how does this just push our team members out of the way. But most importantly, I think we've got to really think through how this can be done in a safe and ethical, transparent, and responsible way so that we do get the outcomes that we want. The one piece that I would like to talk about that I think is critically important for all of us who are leading organizations who are involved in this is to really be better buyers of this technology, if we're buying it that way, or the partnerships associated with this. Because so many times we don't put the same rigor in looking at technology as we do in looking at medical devices, for example, or other things that touch our patients. So that's kind of my yes and no answer on this. I think there's great opportunity, but there's great challenge.
Great, thank you. Lauren, what practices and priorities are you seeing at Accenture emerging among provider organizations here?
Yeah, thanks for the question, Doug. A lot of this is consistent with what Brian just talked about. On one side of the equation, we're seeing rapid innovation and promise. On the other side, we're seeing health leaders and practitioners are experiencing significant strain. So we're going to talk a lot today. I'm sure capacity is going to come up, cost is going to come up, security is absolutely going to come up. And we're seeing this excitement around innovation and then these true pressures. So that's resulting in an environment of excitement, of experimentation, and then realistically skepticism. But the AI conversations that we're having today are different than they were yesterday, quite simply. Generative AI is changing things. For the first time, we're seeing with tools such as ChatGPT, there's democratized access to AI. So this excitement and the priorities we're seeing are around Gen AI for documentation, for example, clinical notes, opportunities around transforming patient engagement with automated medication adherence reminders that are more advanced than they were previously, workflow improvements, drafting emails, generating marketing materials. And the hyperscalers in the space, be it the Microsofts, the Googles, the Epics, and so on, are investing in this rapid innovation and providing opportunity for health systems and providers to make some of these changes. Now, what we're really seeing is, from my lens, about 20% of providers that we're touching have some type of generative AI in production. The vast majority, if we look at kind of that middle, probably 70 to 80%, have some kind of pilots that are in progress. They're planning for some proofs of concepts. And then the last percentage are really in watching and waiting mode. What we're seeing within those trends is larger systems are definitely experimenting faster and more than others. This is mostly the result of some more discretionary spend opportunities, but also the technical infrastructure, be it the architecture or the resource availability. And Brian mentioned, Joe has some resources that he'll talk about as they think about this. But as there's all this excitement, there's a little bit of a risk in what we're seeing where people are going to Target without a shopping list. So they show up with their shopping cart and they're seeing shiny objects and they're filling up their cart. And that can result in a patchwork of some disconnected pilots and proofs of concepts that are then not necessarily tied to business targets. Yet those that are getting it right, we're seeing a few key things. So they're focusing on testing and trying. Let's go understand the efficacy and the impacts with purpose. If a proof of concept is not successful, they're taking the lessons and moving on. The point of a proof of concept is to prove the concept. And if it's not proven, that's okay, move on. They're really engaging multidisciplinary teams. So that can be the technologists, it can be operators, it can be clinicians. It's the right group that's going to be impacted from the procurement, design, and development and deployment of any solutions. And then throughout that whole process, truly from procurement through adoption, they're always leading with clear objectives. And that's really consistent, Brian, with what you mentioned around being better buyers and focusing on those three key areas. And it's about having that North Star. And that's where we're seeing those organizations that are having the most success in this space.
Great, thanks. Joe, since Lauren mentioned you, what approaches are you taking at Jefferson, large academic medical center, to really explore AI capabilities?
Well, first thing we did is we had to make sure that we had one single approach to AI. And so we did lock down, we got rid of all of the sort of one-off AI technology that was being used by some of our residents or medical students. And we were really locked onto one vendor. I'll leave the vendor nameless, but we really locked onto one vendor. And honestly, we are an Epic shop, so there are a lot of tools embedded in Epic for AI. But for us, we see it, and I think Brian described it right. It's alongside of what we do. To us, it's an enabler of a lot of things that we do in healthcare, and I think it's here to stay. It is obviously very high tech. It's going to get better and better, and we think that we need to be an early adopter and to learn along with the technology. And frankly, though, we don't see it replacing. We see it as an enabler. I think the big mistake that we make in healthcare is we do run after shiny tech objects. And I think Brian said that we don't discern as much as we do for what's the best cath lab or what. We sort of believe everything tech tells us, and we've jumped on to a lot of bandwagons that didn't end up having the return on investment that we had hoped, whether it be clinically, financially, or operationally. We see this as an enabler. And I think what's going to differentiate, and I've heard this thing that, AI is more, has more empathy than do a physician interaction. We think that healthcare is high tech, but also high touch. And when healthcare loses the high touch part of this, we run the risk of being replaced by tech. But I will tell you, as a former recovering cardiologist, a lot of the things that we do as physicians and nurses and providers is very high touch. holding the patient's hand end of life, helping people through things. That is not something that AI is going to replace. AI is going to make us smarter. It's going to make us less dependent on our own memories, and it's going to make us and put data at the point of care in a much more efficient way than it's been in the past. So I think it is here to stay. We are going to be an early adopter and figure out where it fits. You know, there are a lot of shortcomings of AI, especially today in the early days of it. And, you know, AI will invent a story or confabulate an answer. If you ask it a question and it doesn't have the right data, it will give you an answer. It may not be correct. So the stakes are high, and that's why we see it as an enabler, but not necessarily a panacea.
I see. Thank you. Jim, capacity came up earlier as a concern. Is this a challenge that rural providers may encounter? And are there other challenges that might be specific to the rural community here?
Great question. I think some of those aspects of capacity, there are some unique rural hospital aspects that are probably mimicked in other urban environments as well, because capacity tracks back to bandwidth and some level of resourcing. So all of those different pieces have a very rural component to it. We've got 3 training programs, so in the educational space of trying to understand AI in its clinical application and both training capability as well as accessing care and creating that framework. The other parts for us are also in the larger pathway towards population health management in a completely different framework of how do we see AI in that space. And so we're trying to compartmentalize. I mean, it may not be the right approach, but to someone's comment about our capacity to run out and buy technology that we don't fully appreciate, I'm sure I'm the only one that's had the opportunity to invest in some IT products over the years that are probably still on the shelf, that we haven't even pulled down and actually gotten implemented, because all of those things take 24-hour day, 7-day-a-week implementation. My experience is in contrast to a cath lab or a linear accelerator where you got to teach 6 people how to run it, and you're able to implement those kinds of changes. So we're trying to be very intentional about, because we don't have the human resources bandwidth as well as the resources, just the economic resources, to make many mistakes. So that's a key piece. We're also trying to understand what we think is going to be a big part of this is where the payer side is going to come from with their deployment on some of the AI pieces and how we stay connected in some of those spaces. So it's going to move at a high rate of speed. There's no question. It'll probably continue to move much more rapidly than any regulatory space is going to, really be able to keep up with. So
that's a great point. It does seem as more people use AI tools and apply them to more purposes, that hospitals and health systems are really going to need to increase their competencies. So Jim, I'll continue with you here. How should our organizations approach this need for building competencies, given the many uses to which AI could be applied?
So our approach is again trying to think about the skill sets and the responsibilities of positions, and so our revenue cycle team has got a need to have AI understanding, application, and utilization. So what are the skill sets we need to build for them, which may be somewhat different than our internal medicine residency program and what their needs are and how we build that for them. So again, we're trying to build that discipline specific and understand what the bandwidth is within that part of our organization so that they can take on reasonable amounts to continue to advance. I'm not sure we're going to be anything at the tip of the spear. And there's some value to that, because we hopefully will minimize some of our bad choices by being able to be a step behind some folks as we try to leverage it. But it's really going to be about going back to job description. And for us, it's going to be a leadership challenge of having people at different phases and stages of their careers actually understanding what those capabilities are going to be in their given disciplines. So we're trying to build that into some of our management goals on an annual basis of what is it that you're bringing to your space and where's AI and how are you applying it. We've challenged department heads to go out to ChatGPT and get a business plan. Just go ask them for a business plan for your environment just to see what it looks like, what it brings back. And, truthfully, we've had several of them sort of look at me and, half the time I can't spell it if you spot me half the letter. So it's a learning process, and you just kind of gotta, for us, push people through it.
So, Joe, in addition to building competencies, there's an increasing concern about using AI responsibly. What are you doing within Jefferson to follow or pursue that?
Yeah, so we are, so we have an oversight committee that is a clinical oversight committee that, and with our academic center, that working with some of our non-clinical folks to really help define the spaces that seemingly have more development. We're using it right now in risk modeling. So we have a sepsis predictive model that we use AI that's embedded in Epic. We're using it for appointments and using scheduling, a scheduling module with AI. And through our call center is starting to implement some AI related things. We get it where our feedback on the AI generated phone calls is 50-50, but there are direct AI interactions via, like MyChart in our case with Epic. There are direct AI interactions that we're taking advantage of, making the providers more efficient. The big area, and I think it's gotten the most attention clinically, is in imaging. We are using it now on, obviously there's studies now out there on mammograms. We use it I was talking to our chief of radiology, we use it on all CAT scans, chest CTs. And, chest CTs have become so sensitive now. They pick up so many different things. We're actually able to reduce the number of post-processing by using AI as a screening tool for things on CAT scan. It's shortened our radiologist reading time, and we're measuring the quality of the reads, and it's seemingly both efficiency of the radiologist and quality oversight is really making a difference. We're also using it for PACS for CAT scans, and it's available through our PACS system. And so, imaging is obviously the most probably going to be the earliest adopter of this is imaging. I think as a clinician, algorithms such as plugging in data points that are embedded in the electronic health record, trying to create predictive models of outcomes is going to be extremely powerful once we get enough data in the system. Right now, I'm a little worried we don't have enough data in there. And so for us, though, starting to layer in data and being able to share data across health systems to make us all better, I think it's going to be extremely powerful. Last thing we're using it on is in our offices. So we have AI generated notes. Physicians are loving this because AI is creating the note while they talk to the patient. They're not actually typing like they do now with their back to the patient. They're actually able to sit, chat with the patient, and the AI technology is picking up the voice interview and creating a note out of the office visit. And our providers are just enamored with this and can't go fast enough to get this up and running. So we think there's a lot of stuff today that can be done, albeit, again, not a panacea, but, we've got, as with any technology, there are folks that are early adopters. I don't know that we'll be cutting edge, but we're going to be an early adopter of a lot of this. And, our physicians, it's variable depending on their tech savviness, and probably some way as a multivariate analysis is probably age is somewhere in there. The younger, I think, physicians and medical students and residents are really embracing it much more quickly.
Thank you. Brian, you know, AI in different forms have been around for a while. How is generative AI different, and how is it so taking us by storm, if you will?
Yeah, Doug, you and I participated in a conversation with Microsoft a few months ago, and I thought that was pretty interesting, and it was clarifying to me also because AI has been around. We use it for a lot of things, but what's really different about this is if you think about traditional AI, it's really about analyzing data and then performing particular tasks. This new generation or generative AI really excels at pattern creation and using large data sets. And I think Joe's point about the bigger the data set, the less hallucination and other types of artifacts are going to occur. But there's some positive things to that, and there's some negative things to that. So on the positive side, I really do think that this is going to really broaden engagement because it's really going to create really more democratized access. And what that means is that more individuals and organizations are going to be able to use these technologies because there's going to be incentives to participate for the reasons that were discussed earlier. But there are some challenges with this that differ from prior generations, and a lot has to do with ethical and bias concerns. And that's something that we're going to have to be very careful about because, we all think we come to the party with our own set of biases, and we see it in our data and our health systems in terms of underserved populations and et cetera. But the risk of this, while it may be empathetic, the risks of this are just perpetuating data bias, and then certainly unethical uses if really guidelines and oversight aren't in place. So this really ties back to the governance challenge and figuring out how we're going to regulate and govern AI use as it becomes more complex and as more entities begin adopting these technologies. And then how do you regulate something like this in a way where it literally changes every minute of every hour of every day? I think in healthcare, we all go through this trying to create this balance between underregulation, which can certainly cause a lot of harm, but also overregulation, which can kind of kill our efforts to utilize technologies and other things in a positive way. So I really do think as organizations having a governance framework in place, which we do, really has to be adaptive. It has to be inclusive. It has to include all the stakeholders, but it can't really be used as a mechanism of trying to defer decision making. And then on the government side, Doug, I've had an opportunity to sit as an advisor to CISA and on this FBI advisory committee. I do think that the government is going to intervene in these kinds of activities, and we need to have a voice in that because I think it can get oversimplified. And we can talk later about what happened with United and Change and seeing how the regulation appears to be rolling more out at us rather than them. But I think we've got some interesting governance challenges here.
Indeed, we do. You make a good point that it's not just the technology skills, but a great many others that we need to begin to build. Lauren, as you're seeing organizations getting deeper into AI and finding that they need not just technical acumen, but also things like greater data literacy, that's a phrase that comes up a few times. What does it mean?
Yeah, I mean, data literacy means to use AI and get the most out of it and use it safely, we need to understand what AI is and isn't, and that we is a really broad set of people. This includes leaders making the decisions. It includes people using it. It also includes those impacted by it. That can be the patients. If we don't have that understanding across those different groups, there's more risks added to the equation. I mean, a simple example of, Doug, I'll pass this to you. If you were to ask some type of generative AI image generator, give me the picture of one banana, what would you expect the output to be?
Well, I guess I'd expect one banana.
Okay, you probably would. But as we're looking at how these models are trained, statistically, bananas appear together or in bunches. You won't get one banana as the output. It's the lone banana problem that's acknowledged today within the space. So if we don't know the limitations, imagine what this would mean for a diagnostic support tool or something else. If we don't know what those challenges could be, we're then relying on data, relying on technology that isn't able, as we've heard before, to replace. It's about augmenting and understanding how it can be an aid. So what this means for administrators from a data literacy perspective is it's really a new discipline. It's a new area of business acumen. Just as we need leaders to understand financials and the functional and clinical components of their spaces, they now need to understand the value, the capabilities, limitations, risks, and outcomes of AI. Typically, this requires some kind of sponsored training because we're now asking them to take on an entirely new discipline within their business. Jim, this is something you mentioned you're already doing within your teams, is saying this is a leadership challenge. Let's pressure this. Let's make sure this is a priority. But then as you're looking through, like Joe, you had the example of the propensity models around sepsis. So if you're building those models and deploying those models, I would expect, given everything you've said so far, that you had clinicians involved really early. And you probably had nurses who were saying, well, okay, this is what I would want to see on my screen. And if this is the risk score, I need to understand more than the black box of the score. But what are those drivers that are typically in AI Shapley values to say what is adding to that risk? So those users need to know during the design, what's the intent, what are the capabilities and limitations, but then also during training. So before a tool is rolled out, whether it's traditional AI or it's something like generative AI, and people need to learn prompts, there's upfront training. There typically are going to be disclaimers that need to be embedded in workflows and policies, and then it's not set it, forget it. Once AI is deployed in its many forms, there's also checking through deployment what happens to the data, algorithmic, and then behavior drift along the way. And then lastly, when it comes to patients, lastly, but certainly not least important, is about being transparent. So Brian's mentioned some of the security challenges that are being experienced across the health industry today. People have concerns about their data and security and how it's going to be used, and disclaimers around how am I going to use your data? When we look at an electronic record, let's be honest and provide the education and the data literacy opportunity for patients and their families to understand how the providers they're interacting with are using their data within AI.
Yeah, I would I think there's a subtlety, and maybe I'm being a little splitting hairs here, Lauren, but I think there is going to be, people need to understand the shortcomings of AI, but do they actually need, and they need to understand what are the variables that are being plugged in. But to the average practicing clinician, that's not really practical. What they really need is a tool, and not to change. It is an enabler. And if you become so dependent on AI, yeah, maybe you need to be under the covers on AI and really challenge everything. But just like guidelines today, if I'm practicing guideline-based medicine, I don't go back to every primary piece of literature that are embedded in the guidelines. Similarly, with AI, you don't need to go back to every primary literature or every data piece that's in the model that's creating the predictive model. Done predictive modeling in my career, and you don't need to have, you need to understand the shortcomings of the data that's in the, but over time, this is going to become so powerful because the amount of data that's going to be embedded in there. What I would say is it's not going to be a directive. It is an enabler, and it's not going to replace physician judgment or nurse judgment. It's going to make us better, smarter, but it still requires physician and clinician judgment. And I may be a biased observer here as a physician, but I think if we go down the road where we become so dependent on technology that we'll lose the edge in healthcare. But at the same time, I don't know that we need to know all the inner workings of it. So I'm not sure, maybe I'm splitting hairs with what you were saying. I just think that the average it's not practical as somebody who's practiced on the front line. It's not practical for every physician to understand every piece of literature that went into a guideline. They're dependent on AI. Today, they're more dependent on a group of scholars to come up with those guidelines. In the future, it may be scholars with enabling AI to help develop those guidelines, which will be at your fingertips.
Yeah, I
Hey,
think,
Joe.
Joe, this is worth splitting hairs about. I agree with you. We should not be saying, let's use these models to replace clinicians at all. This is an opportunity to say, how do we save time? How do we collate a bunch of information and provide them, like you said, with an enabler, with another source of information that can help them then make decisions? They have a patient in front of them. They can see body language. They can see other things that the AI can't, especially in real time. In terms of the literacy, though, there are different levels of literacy that are needed. We don't need everyone to become a data scientist or a data engineer. Absolutely not. We do need leaders to understand what it will and will not be for their teams. And clinicians do need to understand the limitations, which I think is actually part of that augmentation enabling message of that is what it is and it's not more than that. So I think we're in some ways saying the same thing. And to be clear then, the data literacy piece needs to be adapted to the users. And it doesn't need to mean that everyone goes so deep, but a clinician like yourself would need to be involved in making sure that the well-meaning data scientists don't develop capabilities that then are giving so much extra information within a workflow where it's even adding to the administrative burden.
So, Joe, one thing I'm curious from your perspective, one of our challenges across our delivery system is to try to maintain the value of the relational component and not just become transactional. And so we've been talking about this very much from the provider sort of perspective. I imagine in your practice, you watch some of the transition to the availability of a lot of, I'm going to use the word information somewhat loosely, but you know, people can show up in our providers' offices, you know, with Dr. Internet. Now you're getting into Dr. AI that I'm just trying to figure out how from the provider side you stay connected with your patients or the population that you're managing, because all this information is going to be accessible from their side in some form or fashion, right?
Yeah. Listen, it happens today. You know, I can tell you, seeing patients came from all over the world to see when I was practicing in Cleveland. You know, people would come with reams and reams of data, reams and reams of Google search or whatever. So you're spot on is this is not just, you know, physicians, when I went to medical school, what made me appealing to the medical school people that admitted me were my test scores and my ability to remember and critically think. Those are the two big things in medicine. The memory piece is becoming less important, right? Because we all used to learn our times tables and additions. We now have a calculator, and I don't even know if they teach it in schools anymore because they have a calculator. And so to me, there's a memory piece that is going to make us far better. I'll have a much bigger fund of knowledge at my fingertips than I ever have as a practicing physician. However, I still think there is the high touch and the relational portion of this and understanding the impact on people's lives. It's not just about a constellation of symptoms that creates a disease. A disease is how it shows up in your body and how it's impacting your entire being. And that to me is where we cannot lose sight of the fact that the practice of medicine, the practice of nursing has got that high touch relational piece. And we now know that so much of outcomes is determined by social determinants of health, which are not necessarily, there is a lot of data out there, but that data is not as structured as some other data that we have in medicine today. And so all of those things go into how we treat people, how we create treatment plans. To me, AI provides a foundation for you, but it is not going to replace the judgment and the high touch relational piece, to your point, Jim.
We might step from the clinical application to the administrative. It sounds like from this discussion that organizations, as they're setting their priorities for how to use AI, that those priorities are going to have to fit into the framework of their overall business practices. And I'm asking this question because, Lauren, I think it was earlier this month that Accenture published an article in AHA Trustee Insights on the need for responsible purchasing. What are you recommending?
Yeah, I mean, the way that we've talked about responsible AI within the AI space has really been focusing on technology protocols. We've heard it in different colors in this conversation. This is different. We're on a new brink of how we think about AI, how we think about it within healthcare today, and the role it can play actually in enabling more high touch. I mean, we heard the example, Joe, that you gave around using AI for note taking. That can hopefully increase the high touch interactions that exist. But what that means is it's touching all parts of healthcare, and it's going to increasingly do so. Brian said it's here whether we like it or not. So we need to think bigger. I mean, the National Institute of Standards and Technology, NIST, is one of the key groups within this area that focuses on responsible AI. But what they focus on is typically identifying and quantifying trustworthy and responsible AI in technical terms. Typically, we would see this in data science and informatics and analytics teams where they're applying different methods around selection bias and reflecting on sensitive variables and data governance and data and algorithmic and different types of drift and biases. And there's been a lot of work to augment those to be specific to healthcare, because how you apply those in retail necessarily is different than healthcare. But we need to think beyond that as well. Talking about value, talking about how this impacts investment decisions. This is a return to the basics of not just thinking about AI as sitting in the corner or in a couple of areas of the business, but across the business, and not stopping at principles or technical protocols or guidelines and policies, but embedding this in every single part of the way decisions are made. So that paradigm that Brian had said in the very beginning of this conversation, how he thinks about making decisions across the organization, that's something that now applies across AI. AI is just part of the bigger picture here.
Okay. Brian, I think it's important to point out hospitals and health systems are not the only healthcare organizations that are using AI. But what does that mean then for those third parties in terms of we as hospitals and health systems?
Yeah, so, I can go a couple ways on this. I can go on my rant about United and Change. Want me to do that? What do you think, Joe, Jim? Good idea.
Hey, I'm cheering for you if it makes you feel better, man. Go.
As an example of that, but I also think that we're going to see this prevail in so many other areas that we intersect with in partnerships or as vendors too. But we need to work on that. But let's just start with what's going on the payer side as an example. One of the things that we're struggling with as an industry, particularly on the physician and the provider organization side, is a continued reduction in our revenue. And we're seeing that both not just through contracting, but we're also seeing it through business practices. Denials, increasing denials, more complexity and being able to get bills successfully launched as well as collected on. And I think that the United Change piece also showed us the impact on our revenue cycles. I know for Atlantic, this United Change piece, because it's so prevalent, not just with United patients, but also with Horizon Blue Cross here in New Jersey or other payers, Americare and others, was $100 million a month cash flow issue for us over the last several months. Now, put on top of just that challenge, the use of AI to further make it harder for us to collect money and get paid for what we do. So I really think as organizations, this has to be high on our enterprise risk management plan. It has to not just be our internal use of AI, but it also has to be how those that we partner with or do business with, like United and Change, how we do that. And I think that that's going to drive a whole lot of other strategies about how we mitigate risk in that regard. You know, I'm a private investor in healthcare companies through a fund that I'm involved with, and we don't do any business with Atlantic. So just to be clear about that. But we started a revenue cycle company about 2 years ago, and we focused the first year on creating a safe stack. Our tech stack, we spent a lot of money and a lot of time doing that. And I think that as we look at all of these things that are rolling out, we've got to ask those hard questions to those vendors. How have they prioritized safety? How have they put this as a priority in moving forward? Because I think, as was evidenced, again, with United and Change, there were things that we didn't even know were attached in this that we felt a significant impact from. So again, we got to be better buyers. We've got to ask deeper questions, and we've got to assume that those companies that we're looking at as partners or people who are on our food chain, have they really put the time and energy into this that they need to, and the resources in it to make sure that this is safe by design? And that's going to be a whole new challenge for us as a healthcare field. It's going to be a big challenge.
Indeed. Jim, what business risks do you see for hospitals and health systems that ignore or perhaps delay preparing for AI?
Oh, wow. That's, I think, you know, the patient safety piece is going to be, I guess, fundamentally the foundational risk you don't want to be exposed to. So if you're gonna, you know, not, if you're gonna get behind a curve somewhere in the AI space of having something create a patient safety challenge first and foremost, because to get past that will be a challenge for any delivery system of any size. So that's staying, and again, so those pieces, as well as trying to drive for us, because we just don't have the opportunity to make a ton of choices. We're trying to use the applications to drive the quality of care metrics that are going to be what drive our compensation. Because if we don't get those right, then the rest of them are great, but it's not gonna matter as much. So I think the two biggest risks of the miss, if you will, is on the patient safety and the risk management side of that, and then downstream of not being able to build the pathway of care that's going to produce your better outcomes, that's going to allow you to continue to leverage your declining reimbursement models. So,
Okay, thank you. Joe, I'll ask you, given your experience in the payer side, what risks might insurers' use of AI create for provider organizations?
I think I'll say that I think you run the risk that these insurers now think, because they have access to AI, that they're somehow going to supersede physician judgment, or they're going to have their own set of algorithms, and they're going to say, you know, we don't think that patient should have that based on our algorithms. And so they're going to feel empowered, and they're going to try and use it, not to be held accountable to outcomes, but they're really measuring to one outcome: reduce utilization. So I think that's the first place. The second place I think it's going to be used by the payer community is in replacing their RBMs, which is right now a laborious, you know, phone call, physician bank of phones, and a bunch of data gets submitted. And now they're going to plug it into some AI algorithm and say, sorry, Dr. Cashone, your CAT scan based on our algorithms does not meet the criteria. And they're going to use automation to make more efficient denials around imaging and things like that, or admission criteria. They're going to plug in interqual criteria, and they're going to say, sorry, interqual says, and right now they have a bunch of people that do that. In the future, it's going to be all automated. It's going to be a bank of phones, and you're going to be talking to, and so judgment will leave, and so I do think that um, we're going to have to understand that the insurers are going to see this as a way to be even more what they feel is more knowledgeable about care delivery. And many of them are in care delivery now. I mean, Aetna and United is the #1 employer of doctors in the country right now. And so it'll be interesting to see how their providers adapt AI. But I think on the insurance side, it's going to be used as a governor in a lot of ways, and it's going to be used as a source for denials, which we spend time and energy all the time on, and every health system does, and it's gotten worse. And so I do think that we're concerned about that. I think we're going to have to develop our own, and I think the more that we can start to take the friction out between health plan or healthcare delivery and healthcare financing, and hopefully there will be sort of this come together of how do we use AI to take that friction out.
All right. Before we turn to our audience questions, we do have time for a speed round. So I'm going to ask each of our panelists to offer their advice on what structures we need in place to design and develop and deploy effective AI solutions. And Joe, since you were just talking, I'll start with you. If you could elaborate on something that Jefferson's been doing.
The first thing, my recommendation is, if you're not started yet, or I would get a group of administrative people, IT or tech people, your clinicians, your nurses, and get a group together that is sort of this AI oversight committee, and start to pick places where you're going to implement it, and then collect that information very quickly so you understand how it fits into your health system, how your clinicians are adapting it, how your operators are adapting to it, how are your nurses using it, and understand where it fits in your health system. Because everybody is, every system is wired a little differently. And I don't mean literally, I mean, everybody's just a little in a different place. Rural health, I think, is going to have some benefits to this because, the fact that specialty care not always available in rural areas, they maybe have access to some element of at least some idea that there may be some enablement of specialty care. So I think you have to adapt it to your own system, and I think you need a group of people that are going to sit and spend time understanding how it will be rolled out in your health system. It can't be done from the C-suite.
Okay. Jim, since rural came up, what are the special opportunities here that rural providers have to design and develop and deploy?
Right. So I think there are going to be a number of approaches, and I think Joe's right. You've got to get some level of focus, because if you can't, it's going to be a little bit too chaotic. But we're focused on the ambient sort of solutions and physician documentation processes to help improve. If we can find the technologies and the applications that help improve their quality of life, their ability to get the things done that they need to do, we believe it will help leverage into other spaces at some other point. So we're trying to start in the places that, again, improve patient safety and improve the work life of our team. So for nursing and for physicians, how do we build that? On the backside of some of the administrative things of revenue cycle and using bots and all that sort of thing, where that can all go on and not really necessarily interrupt the care part of the organization. So we're trying to do that, and then figuring out how to have its applications in the population health. That's the part where we think the care path and sort of puck is headed, and that's where we're going, and we're trying not to let it be just too acute care centric of how we deal with some of those spaces.
Sure, thanks. Lauren, what recommendations do you have on deciding what to choose and how to make the most of it? In fact, we had a question just come in asking about red flags for evaluating vendor partnerships. So maybe you could talk a bit about how to choose. What are you looking for in choosing the right vendor and then making the most of that solution that you've chosen?
Yeah, that sounds good, Doug. And I know we're still in a bit of a speed round here. So I think that there's really four pieces. So one is focusing on value. So the points about bringing the right people and having that task force, bringing them to the table in the beginning, aligning to your strategic posture. Do you want to be a leader? Do you want to be a leapfrog or laggard? Who do you want to be? And then understanding what your barriers are very early. So if you're going to evaluate a new AI capability, well, know what your current technical infrastructure is, know your budgetary constraints, know if certain decision makers are going to aid or maybe be barriers to change, and then think about how any of your build, buy, and rent decisions are going to fit within your broader focus around risk tolerance, scalability, durability, and all of that focused on what are your key priorities as an organization. So that's the first part on value. The next part is stay clear-eyed on compliance, but don't frame it as a constraint. So across different use cases, we're oftentimes seeing that the same types of compliance measures are being focused. There were some great points made earlier where the regulatory environment for AI in healthcare is noted as fairly immature, relatively immature. There's questions around, are there going to be FDA nutrition label type things for AI models? We don't know if it's going to go in that direction, but focusing on whenever you're making business decisions, data engineering decisions, and data science decisions, applying the hygiene, considering your jurisdictional requirements, respecting copyright and agreements, safeguarding your intellectual property. Those are all really important considerations. And then thinking about the trade-offs of risk and reward for financial and reputational hazards. So that's kind of that next piece around compliance. Two other pieces that I would say are big. One is trust is the currency of healthcare. So you've heard Joe really focus on this earlier around this is about a high touch focus. This is not going away. It's always going to be central to healthcare. So think about how any type of conversation you're having around AI with any vendor, how is that going to add fuel or friction to your trust ecosystem? Is it going to help your providers? Is it going to help your operators, help your patients? So be human-centric in the design, also in the adoption, but it's all about trust. And then lastly, and maybe Brian, you'll get into this more, as this has been a focal point, but focusing on security. So whenever you're having conversations with vendors, this has been stated before, security is moving from critical to sacrosanct. It's just so important. So this applies to data provenance, storage, access controls, and then of course, vendor management in those conversations.
Great, thank you. Brian, I'll end the speed round with you. Earlier, you mentioned the need for partners. Just how important are they to succeed with AI?
You know, I think that this is an area that really does set up for partnership, and we may see a new wave of partnerships get created using this as a reason. And there are several reasons why. The first is that there's a talent war going on right now. And, you know, if you look at folks that have these kinds of experiences and are working in this space, I think that that's going to be a motivator to create partnerships, is just access to talent. The second is expertise and experience, with experience being the one that is going to gain every day. And so again, thinking about it in that piece, certainly sharing resources as well as scaling capabilities, because you need big numbers to do these kinds of things. And then certainly we've talked about risk management, giving market access and insights. Everybody's going to be, you know, we used to think about this as a competitive advantage. Everybody's going to have access to the same thing. And so the real question is, how do we work collaboratively on that? And the same thing with innovation and competitiveness. I think that this, to some extent, has an opportunity to level a playing field or leave some behind. And I think the organizations that embrace partnerships are not going to be left behind.
All right, thank you. Well, panelists, I really do appreciate the time. We have a few minutes left, and Jen, if you don't mind, I think I'm going to move straight into a few of the questions that have come up from our audience. And I will pose them, and panelists invite any of you that wish to offer a response. One question that's come up, is there any data, any evidence yet how AI is impacting patient outcomes? I think we heard some examples earlier of the impact on clinical care, but Where are we seeing in terms of patient outcomes? And that could be clinical outcomes. It could be perhaps experience.
Joe mentioned earlier radiology. I think that's a huge area. We had a all boards meeting and we had a presentation on AI at that, and we had a radiologist out there, and his final comment was, would you rather have a radiologist powered by AI or not? And I think, Joe, you made that comment particularly around findings that somehow get lost because of the way clinical data is presented.
Yeah, you know, the statement that most physicians are saying today, physician is better than AI, and physician powered by AI is better than a physician alone. And so, and I do think we're going to see care gaps that are going to be easier to capture and to not miss anymore because of AI. It's just the power of it is just gonna make us, the care gaps will be much easier to fill.
Time for one more question from the audience. The question is, how do we balance the desire for innovation with the need to protect patient rights and security?
Laura,
Lauren,
you seem
like
to
you
have
wanna-
studied this.
Yeah, so I think we've talked about this in a couple different ways, and it's about making the right decisions about the right AI solution early. So simple things like opt-out, consents, those things can be offered early, but then the rest of it is around making sure you look before you leap. So if you have a shiny object, we've talked about that a few times today, making sure that you're measured on how is this going to impact a workflow, how is this going to impact those who are using it, and then those who are going to be impacted downstream. It's about being measured. So excitement is good, but excitement can't create more risk. There needs to be discipline around decisions, and that's kind of that back to that basics concept.
All right. Well, unfortunately, that's all the time we have today. Panelists, again, thank you for taking time with us. Jen, I will turn it back to you.